Continuing mobile education for emergency medical services providers. This is Geriatric Psychosocial Issues, Episode 1, Elder Abuse and Neglect. At the end of this episode, you should be able to define elder abuse and elder neglect, name strategies for identifying elder abuse and neglect, describe key physical exam findings in identifying abuse, and understand key documentation points.
The current working definition of elder abuse is really more better defined elder mistreatment. Elder mistreatment is a little more encompassing of really what the subject entails or what the problem is. And I think that defining elder abuse, elder mistreatment, you have to look at an ongoing situation where a person 60 or 65 and older, depending on how you define an elder, is being intentionally and purposefully mistreated, either physical abuse, verbal abuse, financial exploitation, active neglect, or sexual abuse. It's one of those 5 categories. So really defining elder abuse as an ongoing pattern of mistreating an older person and taking advantage of them to the perpetrator's benefit.
Elder abuse is defined as a pattern of intentionally and purposefully acting in a way that harms the older adult, including physical abuse, emotional abuse, sexual abuse, financial exploitation, and active neglect.
Neglect is an area where there's, I think, a lot of maybe ideas or wrong ideas. Elder neglect, as we see it, there's really 3 areas of elder neglect. The first is self-neglect, where a person, I often use the case of the quote-unquote cat women, the people that live in a house that's cluttered with newspapers halfway to the ceiling. There's only a little pathway down the middle of the house. The house has very bad odors to it. That's a self-neglecting person. That really has much more to do with adult protective services, and that's really where referrals should be made, because adult protective services, which is the county entity that deals with abused, neglected, self-neglecting adults age 18 to the end of life, that's over 50% of their caseload. Adult protective services is more geared to ascertaining the risk of a person, an adult, a vulnerable adult who is self-neglecting. The second category of neglect is really, we define it as one of the categories of elder mistreatment, elder abuse, and that's active neglect. Again, you have a individual who is being purposefully and intentionally neglected. That would be over-medication, under-medication, deprivation of food, not being allowed to see their doctor, isolated in the house. Maybe they have a dementia and they're wandering, and so the family is purposefully isolating them and not taking them to the doctor, not giving them the things that they need for a quality of life. That the perpetrator, that is the abuser or the neglector, is gaining in some way from that. Maybe they don't want to spend the money in order to get the proper medications, home health agencies involved, adult daycare, to meet the needs of that older person. And so they are selfishly controlling the situation, very similar to power and control that we see in domestic violence situations. And there has to be, again, a gain. So we have intention, we have power and control, and we have gain for the neglector. That's active neglect. The last category is passive neglect. Passive neglect is really just based in ignorance. That's when you have, for example, say a 90-year-old husband who's caring for his 89-year-old wife. They've been married for 65 years. The kids have moved away. Their doctor has retired. They're pretty isolated, and he is trying his best to care for her, and she has an impairment. She has Parkinson's. She has some other disease. Is wheelchair bound, and he's trying his best. but he is not able to meet her needs, and she is becoming malnourished. She's not getting the medication she's need. It's a matter of dictionary definition, ignorance. He's uninformed, he's uneducated about what's available, so you may show up on the scene and think that this is a horribly abusive situation, when in fact the caregiver in this scenario really has never heard of adult daycare. They may not have a doctor. They may not have seen a doctor in many, many years because their doctor, again, is retired or moved. If he or she, the caregiver, is then informed of their options and their choices, and they follow through for the care of the care receiver, then it's really considered passive neglect. It's a matter that they just didn't know what to do. That one is pretty easily remedied by community resources.
There are three main types of neglect. Self-neglect is when the individual fails to meet their own physical or emotional needs. Active neglect, when a caregiver intentionally withholds care or necessities. And passive neglect, which is the caregiver unintentionally withholding care or necessities due to limitations.
We are all part of a team that evaluates and assesses elder abuse and neglect. And we all have the ability to bring what we see, including you in the field, to the attention of the team that will assess the patient. So I view elder abuse as what we call geriatric syndrome, and that means that each of us as healthcare professionals can contribute to the assessment, whether we're a physician, whether we're the nurse, the social worker, the EMS professional, perhaps the clergy that's involved in the case. But in addition to that medical team, we do need to understand the psychosocial aspects, and we have to understand the community aspects. So what we see, for instance, in the field has significant impact in terms of what I, as the physician leader of this interdisciplinary team, can provide. EMS is really the eyes to this issue because you are the first person on the site, and you can be the eyes and bring back information to the healthcare team that will assess the patient. What I'd like to do for this is to break it down into the types of abuse. So when we speak to what are the signs of physical abuse, they may be apparent to our visual sight and part of our assessment of the patient. It may include bruises, welts, it may be a fracture of an individual. Whatever we see, we need to look at objectively, and we understand that certain aspects can indicate abuse more than others. And we're learning more about that all the time. But if we were to see, for instance, a bruise across the left side of the cheek, one could imagine a slap here. And so if you saw a bruise that had linear streaks, it would be important, for instance, to document that. The job is not to understand fully at that time, is it abuse or not? It's really more to be able to document what you've seen. Psychologically speaking, for psychological abuse, people may seem resigned to an environment, again, that doesn't seem to be appropriate for that elder to live in. They may be depressed. They may exhibit signs of hopelessness and that there's no opportunity for them to change. When you begin to think of neglect and what are the signs of neglect, particularly as an EMS provider upon the scene, what you may see is an unkept environment. There may be signs that the housekeeping has not been maintained. You may see some areas that people tend to hoard materials, but importantly, what you'd be looking for is just signs of that would really cause a public health issue. For instance, excrement from animals, waste, perhaps the refrigerator where you might be looking for the MOLS form may not have any food in it. And so that you can begin to look at those aspects of neglect. And when come upon the scene, all of these are, again, the kinds of information that you want to document and bring back to the team when the patient is taken to the emergency room.
Well, there's a number of good things that EMS providers can look for when they're trying to identify elder abuse. Most markedly in your physical exam, you'll often find things that are indicative of potential elder abuse. Also in your evaluation of the patient and discussion and interview of the patient may give you key indicators of abuse may be going on. And lastly, and I'll go into more detail on all three of these, is kind of the environment, that the patient is in. So we'll start with that, looking at the environment that the patient is in. Generally speaking, you may be entering into a uncleanly environment or very disorganized or cluttered environment. Now that can either be a function of the individual themselves or it could be a function of the environment that their caregivers are giving for them. So taking a look at that environment is really important, looking for clutter, looking for bedpans or urinals that are laying around, or is the patient actually still laying in excrement or urine? Those types of things can kind of be a key indicator of caregivers not giving as much care as they should to the individual. When we start talking about the interview of the patient, certainly the things that the patient say to you as a provider could also give you some indication that there's abuse going on. Are they indicating depression? Are they indicating that they're not getting their medications as they're supposed to? Are they indicating that they've missed doctor's appointments? A number of different things along those lines could lead you down the elder abuse road. Your physical exam is going to be equally important. Certainly if we're talking about physical abuse, that's where we'll find the majority of what's going to give us our hints. Are there bruises that are in different levels of healing? Are there burns that aren't explained? Are there injuries that aren't being talked about? So all of those things can lead us to elder abuse as well.
EMS is key in identifying vulnerable and mistreated adults. Things to look for include environmental, physical, and interview identifiers.
It's absolutely critical to document cases of elder abuse and neglect, especially in New York State. Let me start out why that is, and then get to the specifics. Much to many people's surprise, New York State is one of only 5 states in the United States that does not have mandatory reporting for elder abuse and mistreatment in the community. All 50 states have it for residents of nursing homes and adult homes. All 50 states obviously have it for child abuse. But where 95% of our elderly residents live, which is in the community, in our neighborhoods, in our towns, there is no mandatory reporting for elder abuse in the community. We are a voluntary reporting state. So the reality is that in New York, we have no database, we have no system, therefore we have no clue of how prevalent the problem is. And we have New York City with, 8 million people who live in it. We have no idea, we have no data of how bad or good the problem is in this state. If you don't have that data, how can you adjust policies in your department, in your agency? How can we pass laws to address the issue? How can you provide resources to victims or service providers to meet the victims' needs if you have no idea how many victims are out there? So that's one very important thing to document. Maybe even more important is that down the line, some of these cases in fact end up going to court for guardianships, Article 81 guardianships under the mental hygiene law. An extremely important piece of these court hearings, and I've been involved in many of them, is in order to go for a guardianship, you have to show that that adult, that often older person, is impaired enough that they're at risk to themselves or others. If you have documented the number of times that you stepped out of the house, what you've seen, maybe what the person has shared with you in terms of how they're being treated, the physical surroundings, the caring condition of that older individual, those documents or those notes, as insignificant at the time as they may seem, may be a critical part in being subpoenaed for court for a judge to make the determination to protect this older adult. because many of these older adults who are victims, they can't defend themselves. They can't really fight back. So it's up to the court through Adult Protective Services or maybe another family member petitioning for a guardianship. It's the last protection they have that might save them from a horrible death or a horrible continuance of a living situation. So documentation is absolutely critical. One thing we say, and it's a truism in elder abuse cases, is elder abuse, once it begins, increases in severity and frequency over time. You may be coming in halfway through a scenario where you're called in on an emergency from a 911 call or a neighbor calls. You may be halfway through it. If you can start to document there, as the situation deteriorates later on, you can help show the pattern. So again, a determination by a court can be made, perhaps, that can protect this person who can no longer protect themselves. So documentation is absolutely critical in establishing numbers and establishing a course of action.
There are a number of ways that you should document elder abuse or suspected elder abuse on your medical record. One of the most important things is to be specific and elaborate on any answers that were given to you that you think would lead down that road of elder abuse. Using things like specific quotations. So as you ask your patient questions, document the exact response. As you ask the caregivers questions, document the exact response. That exact response could better frame the potential for elder abuse for people that are investigating it down the road. It is important to document all of the same things that we would document on a normal medical record. So we do an excellent subjective documentation, everything that was told to us, making sure we're getting all sides of whatever the issue is at hand, medical, whatever. It also is really important in the setting of a potential abuse case to do an excellent objective documentation. So really documenting the environment, especially when we're talking about hygiene issues or we're talking about environmental issues that may be able to be referred to Adult Protective Services. Also, the physical exam is going to be critical in this, especially in settings of physical abuse. What are we finding? Are we finding bruises at different stages of healing? Are we finding gloving burn injuries? Are we finding signs of malnutrition, clothes that don't fit well? All of these things on the physical exam might also lead down that road of potential elder abuse. Our documentation of our actual impression of the patient, is the patient looking malnourished? Is the patient dealing with multiple conflicting medical issues at the time? So all of those things will lead down the road on your documentation of either potential elder abuse or not, and give the investigators later down the road more information to work on as they're developing their case in this particular instance.
In New York State, EMS is not mandated to report elder abuse, so documentation is critical in helping patients. Some documentation tips include being specific and objective, using direct quotes, describing the environment, and indicate physical exam findings. By the end of this episode, you should be able to define elder abuse, elder neglect, name strategies for identifying elder abuse and neglect, describe key physical exam points, and understand key documentation points.